fun colors.
Everybody else?
Good morning.
Morning.
How's everyone?
Oh,
Very
it's another day, and
It's another day in Connector Land.
yes, it's another day in Connector Land.
And so many ties. Wow.
We're on best sartorial behavior, Nancy.
Oh, well, I'm on vacation at the Cape, so you're lucky I am wearing a shirt, not a bathing suit. So there we go.
Good morning, Lou.
You're really lucky. Michael, good for you. No tie. I didn't think. Excellent.
I don't think Gary has one either, Nancy.
Oh, that's why he has his hand up like this, so you can't
Yeah.
tell. There you go.
There you go.
Oh,
Hey,
Lou,
Lou.
I knew we could count on you.
I did wear my Mr. Rogers sweater vest or cardigan.
Well, I have on my vaccines, safe and effective since 1796 shirt.
Oh, yay.
And I also have on Ruth Bader Ginsburg socks. So there we go.
Excellent.
Nancy, I think the commissioner in Pennsylvania, who's a friend, her cat, if I recall, is Ruth Bader Ginsburg.
Is that Jessica?
It is, yeah.
Yeah, Jessica was a student at, actually very unfortunate, the School of Public Health and the Kennedy School, we were competing for her and she made the unwise decision to go to the Kennedy School, but she's done pretty well.
I'll remind her of that.
Yeah, well, yes. Tell her I'm still bitter.
I will.
She's a wonderful person.
Yeah, she is. She really is.
Good morning, Cassandra.
Good morning. How are you?
Good morning, Secretary.
Morning.
Whoa.
I've been for at least a little while. Like I still exist outside of the Charlie Mary Lou show.
It's good to see you.
Good to be with all of you. There she is, Nancy.
Good morning, Secretary. It is lovely to see you outside of a press conference, but thank you for everything that you and everyone are doing. So I can't even imagine.
Here, here.
It's nice that you got a shout out from Tony Fauci.
Massachusetts did, yeah.
Yeah, which is
That
good.
was nice. That was nice.
Yeah, that's good. I have Tony Fauci socks too, but I'm not wearing them today.
What?
Oh, I was saying earlier that I'm on vacation and I have on my Ruth Bader Ginsburg socks, but I also have a pair of Tony Fauci socks.
Oh, do you? Oh, great.
Yeah, we sent him a pair, a number of people at the school, and he sent us a photo of himself wearing them. So, but he will deny that.
I don't know how he does it.
I don't either. I really don't know how he does it. But.
I really don't.
Good morning, Faye Ruth.
Good morning, everyone.
Lauren, Cassandra. Good to see you.
Good morning.
And good morning, Matt.
Good morning, Louis. Good morning, everyone.
Morning.
So I think we're awaiting Mark, Michael, and Dimitri and Rena.
Hello, Matt.
That secretary. Good morning. Hey, how are you?
I exist. I could just take my and they let me back into, I could just put it like my little bobblehead. Like we could just, so Nancy, I don't have socks with my face on them, but I do have a little bobblehead that somebody gave me.
It's good.
What do you do with these things when you're no longer secretary, you know? Anyway,
Good morning, Mark.
do we have a quorum?
We certainly have a quorum.
Good morning.
And so I think Rena, Michael, and Dimitri, but it's 9:00 a.m.
All right. Well, should I call the meeting to order?
Goodbye, me.
You'll join. It's actually nice to be punctual again.
Hi, Rena.
Good morning.
Good morning, Rena.
Good morning.
So, good morning, everybody. It is July 9th. I'd like to call the meeting to order. This could be like a 30-minute, you might have me for 30 minutes and then I might actually have to pop off, but I did want to be with the connector, the board and the staff for at least a few minutes. One, to thank everyone and to thank the connector staff in particular. As you know, I asked them last time you saw me, it was asking the connector to step up and help us in the Commonwealth to set up the Community Tracing Collaborative, which in the unbelievable way that Louis and Vicky and their team can do. We announced it on March 30th. I think April 3rd was sort of really started the work. April 12th went live. And as we think about a second surge, great work is happening now between the connector and the local boards of health and DPH to refine what quickly was set up and actually has become a national model, even with its lumps and bumps. And I'm grateful to the connector board for the willingness to sort of take the leap with all of us during this time. Truly, and without the connector losing a beat. And in fact, the connector and working with DOI and everyone, right, continuing to ensure people have coverage in Massachusetts. So with that, I really did want to see if I could carve out some time to remind myself that I once had another life of being secretary and the board chair of the connector. And when I do go back to being secretary full time, you will never hear me complain about my schedule ever, ever again. So with that, may I ask for approval of the minutes of the last meeting, which was May 14th?
So moved.
Second.
Is there a second?
Second.
Are there any changes or additions or revisions? Do we have to do this by roll call? Can somebody remind me, or can we just do?
Kathy or Andrew, do you have a recollection on this?
I believe we
Done
did
roll
this
call.
last time.
You have to do roll call?
Yeah.
Yeah, okay. So if we could do this by roll call, please?
Louis, you want me to roll call?
Yeah, if you could.
Okay. Commissioner,
Yes.
Michael,
Yes.
Ruth,
Yes.
Mark,
Yes.
Cassandra,
Yes.
Matt,
Yes.
Lou,
Yes.
Secretary,
I'm
Nope.
I'm abstaining.
Lauren. Okay. Nancy,
Yes.
Rena.
Yes.
Great, thank you. All right, let me turn it over to Louis.
Thank you, Secretary. And I would add my thanks to everything that you do on behalf of the Commonwealth. Good morning. Exactly 15 months ago, on April 9th of 2019, we came to you asking for your approval to build a new building and enrollment partnership with Softion Incorporated. A few months later, we asked to engage with Fanuel Incorporated, a firm with excellent references on our call center operation. Today, we are a few days into a transition that has been largely successful in improving our enrollment and billing systems to the benefit of our members. But cutover is having a rocky start on call center operations, which we are all working to resolve as soon as possible. The call center opened on Monday with insufficient staff ready to handle call volume. Members experience long hold times, and the abandonment rate on calls has consequently been very high. Because call center staffing issues can take weeks to resolve through hiring, training, and onboarding processes, we have been working with Faneuil and with our prior incumbent, NTT, to suggest that Faneuil bring on, through subcontract, a number of contact center staff from NTT that can add both the resource effort as well as some experience to their start out. We expect that the subcontracted staff would be plugged into the Faneuil customer support systems by early next week. And to be clear, the subcontract is in final stages of review by both Faneuil and NTT. It is not yet signed, but we expect signature. And we expect that under the new arrangement, they could both support the call center through open enrollment and also expect the remediation to bring call center capacity to acceptable levels. Our members and assisters deserve excellent service, and we of course will not stop until that is attained. Through the new enrollment and billing system, members are able to access new payment options through a redesigned and streamlined payment portal, including a pay by phone option, additional auto pay settings, and online customer support for some billing questions. Also, more content is available in Spanish, including notices and bills. This is the first step in a sizable move forward in Spanish content, with the expanded Spanish online experience anticipated for later this summer, including the application for coverage being available entirely in Spanish. Also on today's agenda is our first presentation on seal of approval, as you consider giving conditional approval for the connector to proceed to analyze carriers and plans for 2021. This is always one of the most important processes we manage each year, but I do want to identify one particular issue that we are working through. Always, which is currently, until recently, a one license carrier that participates in our connector care program, is creating a new licensed entity that Always is proposing for its connector care offering. Our preliminary review observes that plans offered through the new license would continue to provide access to the partner's healthcare system, but would materially narrow providers covered in certain regions. Member access to care is a key priority in our ongoing review. To this point, Always has been responsive and collaborative in answering our questions and requests for additional information. And while we are asking you today for a seal of approval vote, a conditional vote that allows our analysis, it is not the final vote on seal of approval, and we will keep the board informed of developments over the next 2 months and be back in September for a final binding vote, along with a clearer picture on the Always offerings on their narrower network. Our agenda today also features details on our latest member survey and asks approval of our fiscal year 2021 budget. I want to thank you in advance for your feedback and guidance as we go through a very full agenda. I'll be open to questions right now, but otherwise yield to the board chair for calling up topics.
Any questions, Louis, before we get into the next part of the agenda? All right. Yes, I'm sorry, Nancy.
When do you think that the call center issues are going to be resolved? How quickly?
I'm going to be conservative and say towards the latter end of next week. So I think we're going to have 2 rocky weeks of cutover. Staff should start being added early next week, but I'm going to give them time to make sure we're all set and stable and doing what they need to do. But I'm suspecting the very end of next week.
And then is it possible to track calls that were abandoned and follow back up with those people once we can? Are we doing that?
It is, and that's our requirement for Faneuil to undertake at this point.
You okay with that, Nancy?
Yeah, I mean, I'm okay with that. I mean, I'm biting my tongue because I'm sure whatever displeasure we express about Faneuil's performance on this will be nothing compared to what they've already heard from, I'm sure, you and the staff. But just so it's clear that the board, that I as a board member, and I imagine every other board member, finds their performance completely and utterly unacceptable.
Yep.
Yeah,
it's very, very disappointing. And Lewis is, well, he talks about it in a very monotone kind of way, has made it very, very, very clear what the expectations are and what the deliverables are. So, no. All right. Anything else?
Not on my part.
I'm looking forward to the day everything is perfect. It's just not going to be in my lifetime, but they sort of knew what they were getting into with us, and it was very clear. So this is very disappointing, and I think you're generous giving them 2 weeks to get it fixed. So, all right. Next topic. Do we have is there a PowerPoint? I've been on these for a while, so.
There is. And I think Michael Piantanita will be sharing it.
All right, here we go. All right, so the customer experience project, Vicki and Michael.
So our agenda is small today. Michael's going to take you through cutover and what's happening in the enrollment and premium billing area with Softion, which has some good news there. And then my remarks will be very short. We've really covered the call center and where we are, but Michael will take it away now. Thank you, Michael.
Good morning, everyone. So last month, we reviewed the summary of milestone activities planned throughout cutover. We executed on this plan, and as Louis mentioned, the Health Connector is now live on its new customer service platform. A detailed hour-by-hour, and in some cases minute-by-minute plan was leveraged for the system go live, tracking over 700 itemized tasks through completion. There was around the clock participation for several days from many participants, including Optum, NTT, Softion, Faneuil, and the Health Connector. Softion and Faneuil systems were exposed to the public on Sunday, July 5th, around 9:30 a.m., and the first call into the Faneuil Contact Center occurred at 8 a.m. on Monday, July 6th. The Softion implementation of enrollment and premium billing included a conversion of data from NTT for the current plan year, as well as historical data from 2018 and 2019. This process occurred over 2 distinct events, a full data conversion at the beginning of June, followed by an incremental conversion at the beginning of July. Through this process, Softion converted over 2 million enrollment transactions, 8 million invoices, 12 million notices, 7.5 million payment transactions, and over 113,000 auto pay settings. The Softion system is operational and integrated with other systems, including HIX and the carriers. Enrollment, effectuation, and notice transactions are transferring between Softion and the HIX, and the new member portal is available to members and agents through the HIX. As a reminder, the member portal allows members to schedule payments, set up auto pay, request help, and view notices. All carriers have received 834 audit files, as well as 834 daily enrollment transactions from the Softion system. Since go live, Softion's processed about 5,000 enrollments from the HIX. It's also processed about 4,400 payments, totaling almost $800,000, and it's generated over 10,000 notices, which are viewable on the portal. As with any system implementation of this size, we've now entered into our post-go live stabilization period. During this time, the team's actively monitoring system performance and logging issues where applicable. Any critical issues will be resolved with a hot fix, where others will be scheduled for a future release. All issues identified within the first 6 months of go live are covered as part of the warranty period. And the next scheduled release is July 30th, which is planned in conjunction with HICS R21, and that will deliver open enrollment enhancements for plan year 2021.
Michael, does the hot fix mean you resolve it right away? Is that?
Yes, yeah. You put the fix in as quickly as possible. You don't have to bundle it to another release. Any other questions? Great. And I'll hand it to Vicki to discuss the contact center.
Hey, Michael. So Lewis has covered this slide already, which is that performance was not where we needed it to be for a variety of reasons. And once it became clear on Monday at noon that the plan we reviewed with Faneuil prior to go live was not working, we met with them to work on a remediation plan. If you could go to the next slide, Michael. So Lewis has talked about the remediation plan that Faneuil will be contacting with NTT Data Systems. Contract negotiations are underway. We expect signatures momentarily. The good news is close to 90 staff, which includes some supervisors. It includes the folks that currently today answer phones for assisters. It includes document processing. It includes knowledge about our program. Will be trained on the Faneuil and Softion systems when they come over. But the benefit of this plan is that NTT agents already know our program. They know our policies, processes, and the HICS system. So timing can be shortened from a 3 to 4 week timing for training to 3 to 4. And we've already had meetings with Faneuil and NTT to work together an onboarding and training plan to make sure that NTT can come on as quickly as possible and that we want maximum impact as quickly as possible. As I said, we'll be taking general phone calls, but as importantly, the assister calls again, document processing, and backfill. The other thing to note is that when Faneuil started to have less than adequate staffing, we requested that they add classes. So they do have another class of their own 30 agents coming online on July 20th. July 20th is payment week. So between NTT next week and then the Faneuil classes coming on July 20th, we think that by payment week, we should be righted. The medium-term goal of integrating NTT, short-term obviously is to stabilize, but the medium-term goal is to work with Faneuil to make sure that this subject matter expertise that is coming from NTT is transitioned to the Faneuil team who is new to our program. And we want to make sure that they take full advantage of subject matter expertise transfer. We'll be working closely with the Faneuil team and monitoring key metrics to ensure successful implementation of this remediation plan. And then we'll be working with them on an ongoing basis to make sure that they meet our marks going forward. Any questions?
Are there financial non-performance penalties in the Faneuil contract?
There are, Nancy. They started on Go Live.
Beat me to the question, Nancy. That was mine, which is like, what's the consequence?
And then I know NTT had been reluctant to let us hire people. So I presume some thanks are due to NTT that they changed their stance and are helping us out, or what's the?
Well, the way I would frame it is we are grateful to senior management at NTT. When they learned of the difficulties, were really at the table immediately to offer support. So thanks really are appropriate in this case.
The end of the presentation on CXP, unless there's other questions.
Go ahead.
I mean, I think notwithstanding Faneuil's performance, I think congratulations, Vicki and Michael, and your teams and Softheon and everyone for, outstanding performance on the systems part of this. I mean, I can only imagine how disappointing it must be then to have the call center, but concerning as that is, and it sounds like you all have put in place a remediation plan very quickly, that should not detract from what a spectacular job done on that other piece of it.
Yeah.
Thank you, Nancy.
Yeah. The people side,
Yeah.
those systems just worked. But it really is, I mean, given the fact how long this is and all the planning for it, and as Nancy said, really spectacular transition. And hopefully this is really just a 2-week and they can get back to people who've gotten dropped and the like, and the knowledge transfer. And it
will either save you or get you every time.
Thank you. I'm sure you'll be on top of this and you can report back. I'm sure we'll hear if there is a challenge.
Thank you very much.
Well, thank you.
Yeah.
Thank you. Thanks. A lot of hard work. All right. We're on to the conditional seal of approval. This is part of our annual event.
Yes, and good morning, Secretary. Good morning, members of the board. Hello. Maria will be driving. She's pulling up the slides here, and I will just kick us off. So if, perfect, thank you, Maria. So as the board well knows, the seal of approval process is a stepwise annual certification process whereby the connector reviews, vets, and approves plans for sale through the connector, and specifically for participation in the Connector Care program where applicable. The slide you have in front of you here provides a sense of where we are in the timeline. As you know, the process begins early each year with the development of the seal of approval RFR issued in March, and responses come back to the connector in late May. Today's presentation is to request the board's conditional seal of approval, which is a not binding, not final vote of approval, but rather an opportunity for staff to give the board an understanding of the types of responses we received and continue to, and get approval to continue to evaluate these products and plans, along with forthcoming rate information as we head towards the September presentation when staff make recommendations for the final seal of approval to the board. So the team will walk through both the health and dental plan submissions we've received and detail some of the new areas of focus and new initiatives we've undertaken with respect to plan year 2021. As Louis noted in his remarks, in the context of our broader review here today, we'll also share information on the new proposal from Always with respect to its new license, given that it would represent a change to the Connector Care program in terms of Always' regional presence, as well as the networks associated with that presence in the Connector Care program itself. We're not evaluating the broader DOI merged market network adequacy review and approval process for this new license, but rather focusing on the Connector Care program's longstanding, more specific network adequacy standards. We're continuing to work with Always as a result of some of the PCP and specialist and hospital access information, in particular proposed service regions, and Always has been responsive to those questions. While these discussions are ongoing, we want to ensure that the board has full transparency engagement into where the process stands as part of our conditional seal of approval process. So zooming back out to the broader SOA now, we'll please move to the next slide for a quick overview of our guiding principles and goals for this particular seal of approval process. As the staff developed its seal of approval RFR for 2021, we had two key guiding principles in mind, which really centered around the concepts of affordability and predictability. With respect to affordability, we were pleased to be able to lower deductibles in some areas in order to come into alignment with our updated MCC deductible limits. We're continuing to make low gold plans available to members while providing flexibility in design to carriers. And you'll recall that low gold was a concept we prioritized a few years back after the practice of silver loading began to help make sure people had access to a plan that was similar-ish to silver plans. And finally, we introduced a requirement for 2021 to ensure that members have access to at least one major type of insulin at a $30 copay or lower in all standard plans at any meta level in response to the growing body of awareness in the state and nationally regarding challenges associated with insulin access. And finally, on the predictability front, we continue to see predictability as a North Star, both for our members in terms of their membership and coverage experience, and also for the programs themselves. So you'll hear more from staff on adjustments we've made to further ensure that our members have access to a consistent level playing field in terms of benefits and offerings, as well as their online shopping experience. And lastly, we continue to take the importance of predictability and stability in the Connector Care program very seriously and use that lens as we evaluate any proposed carrier, service area, or other changes to that program. So with that, I will hand it over to Sam to take us a little bit deeper into the details.
Thanks, Audrey, and good morning. We'll begin on slide 5 with an overview of the product shelf. The Health Connector received responses from 10 medical carriers for the 2021 seal of approval. These 10 carriers submitted a total of 63 non-group and 77 small group QHPs. As in plan years 2019 and 2020, carriers continue to be required to offer standard platinum, high gold, high silver, and bronze plans on both non-group and small group shelves. Carriers are also required to offer a low silver HSA compatible plan and a PPO offering on the small group shelf. As Audrey referenced, new to this upcoming plan year, the Health Connector will no longer offer standardized cost sharing for low gold offerings, but will continue to require carriers to submit low gold plans within the existing actuarial value requirement in order to encourage more competition at this tier. Renewing membership in these plans will not experience significant cost sharing differences as a result of this change. There's one new carrier entrant for plan year 21, Always Health Partners Select. Under their proposal, the current Always Health Partners carrier would remain on the product shelf, but would no longer participate in the Connector Care program beginning in plan year 21. Instead, Always Health Partners Select, the smaller network carrier, submitted consideration to participate in Connector Care. There are no carrier departures for plan year 21, and as we have permitted in the previous 3 plan years, Connector Care carriers will continue to load their silver tier non-group plans with an additional percentage of premium to offset the loss of federal cost sharing reductions. This chart on slide 6 outlines the 63 non-group QHPs proposed for the Health Connector's consideration for plan year 21. There's a net increase of 7 plans. And the next chart here outlines the 77 small group QHPs proposed for the Health Connector's consideration. And there's a net increase of 8 plans from 2020. Among the newly proposed plans, Always Select proposes 5 new non-group and 6 new small group offerings to fulfill the standard plan design requirements. Fallon Health intends to close 2 non-standard gold plans in 2021. The 90 or so members in these 2 plans will be mapped to Fallon gold plans with a similar plan design and within the same network. Health New England proposes 1 new non-standard bronze design. And Health New England also proposes to sell their catastrophic plan design in 2021. This offering would expand catastrophic plan choice for members in the western region of Massachusetts. Additionally, Blue Cross Blue Shield, Fallon, and Tufts Direct would continue to propose to offer catastrophic plans in 2021, while the remaining carriers would have requested to waive these offerings. Harvard Pilgrim also proposes a new non-standard bronze design, and Tufts Premier has proposed a PPO design for the small group product shelf. New to this year, the 2021 seal of approval requires low-cost access to insulin medications in all standard plan designs. Our goal with this program is to reduce the cost sharing for this medication, especially for members with high out-of-pocket responsibility. This approach would effectively cap the copay for a predefined selection of insulin medications at a $30 copay or lower for all unsubsidized and APTC-only members within a standard plan design. Connector Care members will continue to have access to these essential medications at copays below $30. Thus far, all carriers' SOA responses indicate this requirement will be met, and the Health Connector is working with carriers to ensure proper display in formulary decision support search tools. Additionally, the Health Connector will also continue to require Connector Care carriers to provide key treatments for opioid use disorder at zero cost sharing to Connector Care enrollees in plan year 21. On this slide, you'll see some of the enhancements made in product design to promote clarity in member plan selection. The Health Connector newly required standardized ambulance cost sharing for all standard plans, including in connector care plans for plan year 21. All proposed standard plans adhere to this requirement, and there were no increases made to cost sharing, and in some plans there was a decrease in cost sharing for this benefit. Regarding carrier parity, Tufts Premier submitted a PPO for plan year 21. This expands the Health Connector's small group PPO choice, and the small group product shelf now offers a PPO from all carriers that also offer PPOs in the merged market. We are also working towards clarifications in the shopping experience. The Tufts Health Plan entity in the shopping filter will be updated for open enrollment to reflect Tufts Health Direct and Tufts Health Premier, rather than the single current entity. The existing Always Health Partners entity will also have 2 different labels in the online filtering tool. Furthermore, Health Connector
And
staff.
are those what the 2 labels will be? Always Inc. and Always Select?
I believe we settled on Always Health Partners Complete and Always Health Partners Select. That's the proposal. Lastly, the Health Connector staff revised the existing network alert language. This alert is present in the online plan selection and applies to each plan with a smaller network within the same carrier. This alert also contains standardized language to promote member understanding of the network differences. I'll now turn over to Maria to discuss the new carrier entrance.
Sure. Thank you, Sam and Audrey, and good morning, members of the board. So Sam and Audrey mentioned Always Health Partners submitted for plan year 2021 under 2 distinct licenses, Always Health Partners Inc., which is the existing carrier, and Always Health Partners Select, which is a new carrier with a narrower network. We'll review how this development impacts the Connector Care program in the next section of the presentation, but here we wanted to share an overview of the differences between the 2 carriers. The key difference between the populations served is that Always Select has proposed to participate in the Connector Care program, while Always Inc. no longer intends to serve as a Connector Care carrier. Both carriers would serve unsubsidized APTC only and small group membership. Both the Select and Inc. licenses would offer 1 of each required standard plan design, but the Select license would not include a small group PPO, as they will not be offering any PPOs in the market under that license. We'll review network differences between the 2 carriers in detail in subsequent slides, but in summary, the Select network, while still in progress, is narrower than the Inc. license and focused in Eastern Massachusetts, anchored around the partner system. So Always would continue to be the only Connector Care carrier in the program to cover those providers. Of note, Children's Hospital and Dana-Farber are not included in the Select network, which are generally not covered through other carriers in the Connector Care program. The Always Select service area, as currently proposed, covers the eastern portion of the state from Essex County down through the islands. So islands residents would continue to have a Connector Care offering, which is especially important to the program, as Always is the only Connector Care carrier on the islands and would continue to be in 2021. The Always Select service area does exclude Worcester County compared to the current Always offering, meaning Connector Care members in that county would no longer have Always as an option. The other Connector Care options available currently in Worcester County are Boston Medical Center Health Net Plan, Tufts Direct, and Fallon Health. So in the next few slides, we'll review the proposed changes to the Connector Care program for 2021 with a particular spotlight on the impacts of the Always transition. So in addition to Always Select, BMCHP, Fallon, HNE, and Tufts Direct have proposed to continue their Connector Care participation in 2021. As noted previously, Always does not intend to offer Connector Care in Worcester County in 2021, with their final regional participation in development as they work to finalize the Select network detailed in the next few slides. HNE intends to newly offer Connector Care plans in Worcester County, where they currently do offer unsubsidized and APTC only coverage. And Tufts Direct has proposed to enter Franklin County after signing a hospital contract with Bay State Franklin Medical Center, satisfying Connector Care hospital requirements. And Health Connector staff are working with Tufts Direct staff to confirm coverage of specialty providers is sufficient in the county. So overall, staff are pleased with the 2021 SOA submissions, and it largely reflects stable or expanded carrier coverage, but we will continue to monitor changes for future years that may impact future stability of the program. To go into a bit more detail on the Always Select proposal, Health
Can you just
Connector.
pause? Can you just pause? There's a lot of information. I just want to see if the board is okay to continue, or do you want to pause for questions? Nancy?
Thank you, Maria. Could you say again what you said about Dana-Farber and children? So they would not be in Select. And then you said something I didn't quite understand, that they are for the most part not in any other connector care product.
Yeah, that's right. They are not covered by most other connector care carriers. You know, there are certainly a lot of kind of single case agreements and that sort of thing for particular circumstances, but otherwise they are out of network.
And at some point okay, and then the so Select would not be in Worcester County, but Health New England's expanding. Would the network that H&E is proposing be similar to the one that Always is retreating from? Do we know?
We're undertaking kind of a detailed analysis of the PCP and specialist coverage, but in terms of hospital coverage, H&E does have a wide breadth of hospitals in the county. Quantity-wise, again, they appear to have very good coverage in the county. We're just still working, particularly with our provider search vendor, to try to do that exact comparison, provider by provider, to see the overlap.
And I stumble over the names so much, which we can talk about later, but I find the names of these two extremely confusing, and I suspect that consumers will too. And what's the rationale for not being in Worcester? Does Partners not have a hospital in Worcester?
What the carrier has told us is that in order to join the new network, the providers that are in it right now have agreed to their reimbursement rates and conditions of the contracts under the new license. And it sounds like they have not been particularly successful in that area. They do have one in that area, which is St. Vincent's, but otherwise they do not have hospital coverage there. Okay, so if no other questions at the moment, I will proceed, but please feel free to stop me at any time.
Maria?
Yes.
Sorry, I did have one question just based on the Worcester County question. Could you, for Always, how many lives are currently in Worcester County and as compared to Always on the Cape and the Islands?
Sure. So in Worcester County Always has a little over 500 connector care members right now. So those are the members that would be displaced. On the islands, I can pull up that membership. It's actually quite a few, and Always does not participate on the Cape. So they are not sort of impacted by this change. And for the islands, Martha's Vineyard, they have about 1,300 connector care members and about 900 on Nantucket.
Thank you.
Sure, thank you. So to go into a bit more detail on the Always Select proposal, Health Connector and Always staff have been working together collaboratively to determine if the Select network, which is still in development, can meet these connector care requirements in all regions. Specifically, connector care network adequacy requirements allow a carrier to participate in connector care in any given county only if the carrier contracts with at least one acute care hospital in the county and that hospital provides reasonable access to all residents in the county. So Health Connector staff identified areas of some counties where residents would have particularly far distances to travel to reach the nearest hospital, and we shared these concerns with Always staff. Staff were receptive and added 2 hospitals in response to our feedback and our areas of concern, but we have remaining coverage gaps of concern, and Always indicates its efforts to add to its network are ongoing. So while the Always Select network is still in progress, the data we've received from Always so far shows that the Always Select license will have a smaller selection of primary care providers and specialists compared to the larger Inc. license. But the differential varies depending on the region. And in the next slide, we'll go into greater detail as to what that means for current Always Connector Care members. But to give some examples of the regional differences, Bristol County, which is an area of concern as the network stands now, would have about a quarter of the existing PCPs available in the Select network, about 40% of OBGYNs and 14% of cardiologists. Suffolk County, on the other hand, maintains a higher percentage of existing providers in the Select network, such as 65% of PCPs and cardiologists and about 80% of OBGYNs. Always indicates it is continuing to try to add providers in certain counties, so we will keep the board apprised of network progress. If Always is unable to expand provider access in these areas, we may return to the board at the final SOA vote in September with a recommendation for certain restrictions on their connector care participation, such as a smaller geographic footprint in connector care than what Always has currently proposed.
Can I ask a quick question?
Sure.
Do we have a mechanism to measure other dimensions of access, like how long it takes to get an appointment, how long you have to wait, sort of things like that, to understand if there's a problem beyond the sort of structural problems?
Yes, thank you, Mike. That is another key part of this analysis. So we're waiting on a little bit more data, and those are exactly the types of things that we're asking about. For example, PCP open panels, it's really important for us to know what % of these providers are accepting new patients and that sort of thing. So we're continuing to ask for and receive that data from the carrier.
The other thing
got a question, but do we ex post get information? In other words, say we offered them, as this discussion is going to go or not, but say we offered them, and then it turned out that there was a real problem in terms of access. Do we have any eyes on the ground to get sort of feedback from our members about how they're experiencing the plan, as opposed to getting information from the plan that is going to try and explain to us why their smaller network's okay? I imagine they're explaining why their smaller network's okay. I'm trying to figure out how we verify that.
Sure, no, appreciate that. So I think there's a few things. One is that we are requesting kind of these PCP panel limitation reports right now, so that we can assess the openness of these panels at the moment to inform this conversation. We also have reports due to us periodically during the plan year, and this is all from the carrier, that can tell us, at that moment in time, how things have changed since before the plan year began. We also undertake some of our own analysis, particularly asking our own call center, if there are patterns, and this will certainly be one that we're keeping an eye on as we begin the plan year. And then lastly, we've also implemented kind of a network grievance reporting process, where we ask the carriers a very specific set of questions about grievances that they receive regarding a whole suite of possible concerns. So certainly something we want to have clear eyes on before we make this final recommendation, but also something we continue to monitor during the year.
And if I could also just add, we also, as you know, field regular member experience surveys, which Marissa and Nikita will be talking about later in the board meeting. And we do ask a fair amount of information there about barriers to care, issues, accessing needed providers, et cetera. But I would also say in general, this is an area where we're trying to kind of intensify our line of sight into our member experiences, and particularly the kinds of plans in connector care, because we have been worried about network atrophy over time. And so if you or other board members have suggestions about particular metrics we should be in a formal way collecting, evaluating, we would love to hear those. So would look for an opportunity to talk with you more about that.
Why don't we hold that for when we get to the consumer survey, member survey section?
Sounds great.
Okay, so moving on to slide 16, a key focus in our review of the Always Select proposal is, of course, its impact on current connector care membership. As mentioned, Always members would continue to have access to the partner system, which is key, as Always is the only carrier providing partners access in the Connector Care program. As the proposed Always Select network is narrower, though, some existing members would experience a disruption to their provider relationships. Preliminary data from Always with the Select network as it stands currently shows about 23% of Connector Care members would experience at least one provider disruption under the Select network. As with the shared providers retained in the Select network, this level of disruption varies regionally. For example, about 50% of Bristol County Connector Care members would experience a provider disruption compared to only 18% in Suffolk County or 13% in Essex County. Bristol County represents a relatively small share of Always Connector Care membership, but it's still important for us to review the impact for all members. So depending on where they live, Always members could elect to enroll in a Connector Care plan from DMCHP, Fallon, or Tufts Direct, but members could also experience provider disruption in switching to one of those carriers, and that's part of the analysis that we're working through that I just mentioned. Always has confirmed there's no change in providers on the islands under the new license, which we are pleased to see, as Always would continue to be the sole Connector Care carrier on the islands in 2021. So pending finalization of the Always Select provider network and any subsequent decisions regarding Always Connector Care coverage, the Health Connector is committed to supporting members in their plan selection via online tools and communications. Okay. So that concludes Always section. Any questions before we move on?
Nancy?
It's just a point of inquiry, Secretary Setters. Would you like us to wait to express any concerns until the end, or do you want to hear them now?
I think we should put them out now.
Yeah. So thank you, Mary. That was a really nice presentation. So I just have a few areas of concern. One is, with all due respect to DOI having licensed the plan, I find the name of the plan very confusing. And it's actually a little bit more confusing now that I hear one will be called Complete and one will be called Select. That leads me to think one should be called Missing or Incomplete, maybe. So I think that's the first, and I think we've already experienced this confusion a bit with the two Tufts plans,
Yep.
Which we know created some confusion. So I don't know exactly how to address this if it's already licensed, but I just want to go on the record as saying I think that we're going to have member confusion about this. Particularly, Select could be a more limited network. It could also, people could think it's been particularly curated for you, and it's and I guess partners would say if it's the partners network that it is Select in that way. The adequacy of the networks obviously of primary importance. The affordability of a network and a product that's based entirely on partners would seem to me over time to be a potential concern. And I know in a question I asked earlier that we were told that Partners is anticipating that the Select plan will be less expensive, but that just seems odd to me. And then, a public policy concern, I think, is this challenge of having only one plan on the islands and the Cape, and the kind of market power that gives in this. And so I don't know if there's anything we could do over the next year or so, I think not in the next months, to really see if it would be possible to have any other options. It's just never good when there's a single carrier who then could potentially, say you either have to take what we've accepted or we're not going to contract there, and that would obviously be of a concern. So,
can you clarify what's on the Cape? Because my understanding is Always is the only provider, a carrier for the two islands, and they're not on the Cape. Right?
Yes, that's
is that
correct,
right?
Secretary.
Okay, thank you.
On the Cape, BMCHP and Tufts Direct are the two carriers, but not
okay,
all.
thank you, Secretary.
But Nancy, I was having the same deja vu moment around the name. when the Tufts, I kept like flashing Tufts from whatever year that was on the confusion around names.
Yeah, I think we're just going to get a tremendous amount of confusion. And
on the other hand, I have to tell you, and I don't say this to embarrass my friends at the GIC, there are several plans on the GIC that the names just don't really comport to what the product is. They predate Matt, so I won't. But you know,
thank you for that.
yeah. But you know, I mean, and I'm, you know, I'd like to think I'm a sophisticated consumer of healthcare and understanding insurance. And literally every year, my spouse, who's very smart, literally just says, "These names make no sense to me. Can you go figure this out?" Because it's just, I don't know. I think we have to do a lot around education so people understand exactly what these are and almost ignore the name. It
Secretary.
is, and again, Commissioner Anderson's is not a reflection on you, but the names of some of the products really do sort of just add to the complexity of insurance. And it's hard to not think sometimes it is. I'll just withdraw what I was going to go.
But you're right.
So sorry. Yes, Mark.
Marketing does not mean education.
Right. No, sure.
I have a question.
Yeah, please.
Maria, when are we going to know what the price point is for this new product? I know the carriers just filed, but it'd be nice to know how much lower this product offering is relative to what they were offering previously.
Sure, thanks, Rena. So yes, as you said, preliminary rates have been submitted to the Division of Insurance, so we can work to see what we might be able to learn before the August timeframe when the rates are finalized. But I think that's generally the timeframe.
Okay.
And you did say that always included St. Vincent's in Worcester County?
They did, yes.
Which is not a Mass General Hospital. Mass General, what are we calling it now? Mass General.
Mass General Brigham.
So much the rest of the hospitals in their system, but.
Yes, exactly. They've described it as it's anchored around the Mass General Brigham, thank you, system, then with additional providers added as they were able to come to agreement.
Okay. All right. All right. Are we ready to move on? Dental.
Dental. So I will make this brief, but on the dental shelf, there's no change from plan year 2020. Aldous and Delta again plan to offer plans for sale for both non-group and small group membership. And Blue Cross Blue Shield and Guardian have proposed plans for certification, but have requested waivers for small group sale, which is consistent with prior years. So while the conditional SOA is an important checkpoint for us to seek board feedback and approval of continued submission review, there's more work to be done before finalizing the 2021 product shelves. We'll keep the board apprised of developments over the summer and return to the board in September with our final SOA recommendation.
Okay, all right. So are there any further discussion before we take the formal vote?
I guess just one point to pick up on something, Maria, that you said. It would be very helpful as quickly as you know for us to understand how many people who are currently and always have, in particular, primary care provider relationships that they will have to give up and will not be able to continue by joining another plan. I think that's the kind of missing piece here that I know you all are trying to understand, but I mean, it's one thing to say our network doesn't have as many providers, but you actually could join another plan and keep your relationship. It's quite another to say they won't be in anyone's network at all. And that obviously has a very different impact on our members.
Yes, thank you, Nancy. That's top of our list in terms of analysis. And again, we have a rough start in terms of quantity, but we need to get to that next level of detail. So thank you. We'll definitely keep you posted.
I know we're going to vote in a second. I don't mean to delay us, but I think this topic broadly is really challenging because it fundamentally pits this notion of narrower networks of support negotiation and a bunch of other things which I generally like, with member disruption and confusion and a bunch of other things which I generally hate. And so we can do a certain amount of analysis, like Nancy said, we try to do that, but at the end of the day, there's going to be some core judgment that's going to have to be made about how people are essentially going to be forced to choose between access to PCPs versus access to partners hospitals, for example. And that's
or cost.
Excuse me?
Right?
I missed what you said, Mary Lou.
I said or cost. I mean,
yeah, or cost. No, I agree. I agree completely. And we're so on the plus side, this is the ugly side. This is the result of competition. On the negative side, this is the ugly side of competition, where these trade-offs are made in ways that we're not always comfortable with, particularly if we don't think people are well enough informed. But right now, I think you're going for a vote on the conditional seal. So I'm fine with that, but I think it's worthy of a longer discussion at some point about how we're going to deal with this as these types of issues arise.
Well, I think particularly, I mean, given Always is, to my recollection, the most expensive plan almost everywhere it operates, and given the providers that it has that are not in any of the other plans, one could reasonably imagine that people are willing to pay that premium because they have access, brand preferences, or they have conditions that, or they have access to providers they can't otherwise get. So I think really understanding what the implication of having the dominant provider system in the state now operate not just one, but two health plans is really important.
Mark?
Hey, Secretary, this is Gary.
Gary?
Yeah, I would just say, I think to highlight something that Michael said, I think the challenge for, a big challenge for the connector staff is going through this exercise every single year makes it really difficult to, having to go through it every year, it makes it difficult to make long-term kind of changes, right? Because we're, as we see today, right, these are some big policy discussions that we could have on each of these components, but it's really, I think, a real challenge for the connector staff to have to do this every single year instead of it. And I don't recall it maybe a statutory requirement, but it's certainly a challenge for them.
I was going to add that I just think to Michael's point and to Gary's point, it's going to continue to be a challenge for us. Networks, it's not going to get easier. It's going to get worse, especially with COVID and the loss of revenue that these big systems have felt. So I think we should expect that to be the norm. There's also another trend that's emerging, and that's physicians, primary care physicians who were once controlled by these hospital systems are now breaking away from these hospital systems. It's a movement called direct primary care. There are 99,000 primary care physicians nationally, roughly 4,000 of them, and growing exponentially day by day, are breaking away from the corporate practice of medicine and then trying to return the patient-doctor relationship. So there are some good things here. It's not all bad news, but I guess I would say that to Michael and Gary's point, it warrants more attention by us because it's going to continue to get more challenging.
Yep. So anybody else? All right. So we have a vote. Is there a motion?
So moved.
Is there a second? Any further discussion? All those in favor, and Kathy, you're going to do the roll call?
I will.
Thank you.
You ready? Commissioner?
Okay.
Michael?
Aye.
Ruth?
Yes.
Mark?
Yes.
Cassandra?
Yes.
Matt?
Yes.
Lou?
Yes.
Secretary?
Yes.
Nancy?
Yes.
Rena?
Yes.
Motion carries. All right, we look forward to the next iteration of this. Thank you for all the hard work.
Thank you all.
Thank you. All right, I think we're going up to the budget. Lois?
That's correct. So I'll hand directly off to Carrie and Newper.
Thank you, Louis. Good morning, everyone. Can you see my?
So before you start, I'm going to have to, I actually hate leaving a budget conversation, but I am going to have to step off and hand it over to Michael and folks. So thank you for letting me join for a while. Thank you all for what you do. I have to go back to Command Center world. So be well, everybody.
Yes, Secretary.
Thank you.
Thank you.
Thank you.
So this is easy. We're going to go to Carrie, the new Pearl.
Thank you, Dr. Trenu. Can everyone see my screen? Perfect. So good morning, members of the Health Connector Board. The purpose of the presentation is to provide an update on the fiscal year 20 administrative budget and present the fiscal year 21 recommendation for a vote. So as you know, our budget is heavily influenced by the CXP project. And the variance that we talked about for fiscal year 20 is primarily the result of the shift of the CXP live date from June to July.
Hi, Carrie.
Yes.
I hear the echo back, and I'm just wondering if all of us who may not be speaking might go mute until we do need to questions. That might help.
Sorry, I just flipped through. Let's see. Let me get to back to the slide. Apologies. Thank you, Kathy. Okay, sorry about that. So the fiscal year 20 variance that we will talk about is due to the shift of the CXP go live date from June to July. This is because we incurred the first month of operating expenses for our new vendors in fiscal year 21 as opposed to fiscal year 20. So for fiscal year 20, we do see an improvement of $4.7 million relative to the budget that the board approved last July. We had initially projected a loss of about $7.5 million, and the current projected loss is about $2.7 million, again, because of the shift of the go live date. The fiscal year 21 recommendation is in line with what we submitted to A&F subcommittee last month. From a bottom line perspective, fiscal year 21 reflects a favorable net position of $2.7 million. Compared to fiscal year 20, this is an improvement of $5.4 million. This is driven largely by estimated savings on ongoing costs with our new vendors compared to the prior vendor, as well as the completion of implementation activities. At the conclusion of fiscal year 21, reserves are anticipated to be about $33.5 million. Our auditors recommend about 6 months of operating costs in reserve, so that $33 million represents about 70% of the recommended level. Specific to 21, there is some uncertainty around potential membership changes given COVID and other dynamics that we find ourselves in currently. A cross-functional team has considered various enrollment scenarios, and the budget recommendation reflects overall membership growth of about 5%. With that said, however, we will continue to engage in modeling and analysis to monitor enrollment dynamics, and we will continue to update the board. From an administrative perspective, the costs that we incur on a per member per month basis are stable for FY20 and 21 at around $20.35 on average. We are cautiously optimistic for 22 as we expect to incur lower operating costs with our new vendors, which would obviously favorably impact the trend that we are seeing. But we will wait until first year practices and costs are validated. If there are no further or additional or any questions at this time, I will turn it over to Newper, and she will provide a bit more detail on fiscal year 20 and 21.
Thank you, Carrie, and good morning, members of the board. On slide 5, you'll see a view of current
Hi,
FY20.
Newper. I'm
Yes.
sorry, we've got a little bit of rockiness in the transmission. Can you get closer to a mic or something?
Sure. Is this better?
It's still a little choppy.
Okay. If you could give me a second, Louis, I'll try and switch to my computer audio.
Okay, thank you.
And just in the interest of time, Nooper, if you want, while you do that, I'll go ahead and speak to slide 5. So on slide 5, you do see a view of fiscal year 20 enrollment by program type, which is represented by the bar chart, and each color represents a different program. Relative to the enrollment that we presented in July of 2019, which is the gray line at the top of the chart, current enrollment reflects a 1% decrease in total member months. This decrease is largely driven by Connector Care, where new enrollments during open enrollment 2020 were slightly lower than what was originally projected. We also saw moderate decreases for the APTC only and unsubsidized populations, but these were offset by a 7% increase in enrollment in our small group program. Is there any questions on 20 enrollment? Nooper, I'll turn it back to you.
Thank you, Carrie. Can you all hear me?
Yeah.
Great. So slide 6 summarizes FY20 with the budget approved in July 2019 as the first column of numbers, followed by the ANF update in June, and then the current estimate. The variance shown here compares the current estimate to the board approved budget and reflects a $4.7 million improvement to the net position. The primary driver of this improvement is the timing of CXP and the shift of the go-live date from June to July, as Carrie mentioned. This change resulted in savings on June costs with CXP vendors as operations began this month. It also resulted in a shift of go-live implementation milestones from FY20 to FY21. Secondary drivers of this variance include a modest decrease in enrollment-driven expenses per the 1% decrease Carrie highlighted on the previous slide, as well as final actuarial amounts for GASB 75 and HICS operations and maintenance estimates that were relayed to us by EOHHS. Are there any questions on FY20?
I have a general question. Our biggest source of revenue is the CCTF revenue, which I think is the transfer we get from the state.
Yes.
For that. And all states, I can't speak to Massachusetts, are facing challenging fiscal situation in the light of the COVID epidemic. And I'm interested, I don't know the legal issues and a whole slew of other things, but I'm interested in the stability of our largest revenue source. I guess that's the key question.
I'll let Carrie elaborate, and others on the board may also speak deeply on this. As a revenue source, it's more stable than most, and it's really oriented towards this purpose. However, I also recognize that it's going to be awfully lean times ahead. And so part of our strategy in trying to trim operating expense is really to reduce some of our draw from CCTF. Now, all of that and $5.50 will get you a mocha at Starbucks, but you know, that's the general situation. But Carrie, do you want to elaborate on that any?
Louis, the only other thing I would say is that, you know, yes, we've reflected 45 million for 20, which I don't see any issues with. We have also reflected 45 million for fiscal year 21. We don't have any other information that would seem that this would be in danger. But with that said, like along with Louis, we are, you know, hopeful that with our new vendors, we will be able to reduce our operating costs, and thus we can then consider the revenue.
Carrie, can I just ask one question?
Of course, Nancy.
The GASB 51 adjustment, my recollection is that some kind of intangible asset adjustment?
Oh, GASB 51. So
51.
that's because we have to capitalize CXP implementation
I
costs.
see, okay, yeah.
Yeah, and so we
Okay.
provide that. There is a slide in the appendix on GASB 51. I was not going to review it, but yes, we have to capitalize those costs over 4 years. So we provide that. Sorry, go ahead.
Yes, that's a barn burner of a topic, so it's.
Yes. We provide that information for you so that you can crosswalk this back to our financial statements, because
Okay,
obviously our financial statements have to be compliant with GASB 51.
Okay, thank you.
Thank you, Nancy. Are there any additional questions for 20? If not, I will hand it back to Nooper and she can discuss fiscal year 21.
So before we review the enrollment and budget exhibits for fiscal 21, we'd like to highlight some of the key considerations that inform this recommendation. The first consideration is the replacement of our current premium billing and customer service vendor. We currently expect ongoing costs with new vendors to be about 7.5 million or 18% less than ongoing costs with our current vendor. A key driver of this is the more favorable cost structure with new vendors, which allows for economies of scale. These anticipated savings in fiscal 21 are offset by two cost items. First, the 1 month extension of the NTT contract into July, which is valued at 3.8 million and partially funded by contingency. And the second is the shift of implementation expenses from FY20 to FY21. Both of these offsetting costs are informed by the shift of the go live date from June to July. The second key consideration is COVID-19, as Carrie mentioned, which has created uncertainty around projected enrollment in FY21. 3 potential enrollment scenarios were developed. The exhibits and subsequent slides reflect the middle scenario of 5.2% growth relative to FY20. The high and low scenarios reflect 7.5% and 3.1% growth respectively. Changes in membership do impact our budget, and we will continue to monitor these membership dynamics closely. Notwithstanding these assumptions, the preliminary outlook for FY22 is positive, and we remain cautiously optimistic. Are there any questions? Okay. Slide 9 provides a view of current fiscal 21 enrollment detailed by program type. Relative to current FY20 enrollment, these projections reflect the 5.2% increase in total member months per the middle scenario indicated on the previous slide. This increase is largely driven by connector care, but we also see moderate membership increases for the APTC only, unsubsidized, and small group populations. Are there any questions on FY21 enrollment? On slide 10, you'll see a summary of the FY21 budget recommendation and a comparison of that recommendation to current fiscal 20. The FY21 non-GAAP net position reflects a $2.7 million net gain. Relative to fiscal 20, the FY21 recommendation reflects a 5.4 million improvement to the net position. Key drivers of this variance include the completion of CXP implementation, as well as savings on CXP ongoing costs relative to the current vendor. As stated earlier, this recommendation also includes 3.8 million for the 1 month extension of the NTT contract, as well as 2.1 million in expanded investment to support board-approved organizational goals. Per our earlier discussion, please note that GASB 51 requires the capitalization of $19 million in cash payments for CXP implementation, and then the subsequent amortization over the life of the contract, which is about 4 years. The GAAP net position, which is inclusive of these adjustments for GASB 51, is what will be reflected in the financial statements and is provided here for your reference. Any questions?
I have a question. So I see that we're making a 15% increase in IT, and I understand why we're doing that. But I also see that we're increasing personnel costs by 13%. And I'm listening to Lewis talk about lean times ahead and reducing, the draw. So what are our thoughts about personnel, and why are we making that kind of investment?
Mark, a couple of things, and then I'll let Nooper and Carrie add detail. I think there are some trades here in the sense that we have a vendor relationship that will cost significantly less, but is somewhat more complex because it's now multiple vendors two major vendors in the place of one, and there will be some additional staff needs for the management of that. I think that there are some positions that have been unfilled during the pandemic that are likely to need to come online again as some of our business increases next year. Overall, I want to be very careful with this line. I'm going to let Carrie and Newper elaborate on the detail, but we'll take guidance from the board as necessary to adjust.
Thank you, Louis. I would just say that the increase here is primarily due to annualizing those positions that were brought on in fiscal year 20. So we have a full year of costs in 21 as opposed to a partial year in 20. There were also a number of staff who were brought on to support, I think it's just one or two, CXP 100% of the time, but they will be retained. And so because implementation is done, previously they were counted in the implementation line, now they move back up to personnel. So most of the increase are due to those two reasons.
Do we have other ratios to look at with other state-based exchanges that we might look at relative to our, employee and fringe costs relative to our top line? I mean, Carrie, I don't know what kind of ratios you're using to manage the financial statements, but I imagine that there must be some guidance that you take advantage of.
We're more than happy to look into that, Mark. Thank you for that suggestion.
We'll return to the board with information on that, Mark.
Yeah, I just don't have a frame of reference, and I'm sure my fellow colleagues on the board also share that lack of reference point. If they don't, then please share away.
Are there any additional questions on 21? I believe the vote is next.
Actually, I just realized I have a question. Our contract with the DC Exchange, how does that flow through here?
Nancy, that appears in the first line item under expense, call center enrollment and premium processing.
Okay. Yeah, and how much of the 49 million is that about?
Newper helped me. It's just over $4 million, I think, right?
4 million? Okay.
A little over, Nancy.
Okay, thank you.
But we can get you the exact number.
No, that's okay.
Okay.
I just wanted an order of magnitude. Thank you.
Okay, so I think we're going to move to the vote. And so the Health Connector staff requests that the Health Connector Board of Directors approve the proposed fiscal year 2021 administrative budget recommendation. So I need a motion.
Moved.
And a second.
Second.
Great. And now, Kathy, can we do the roll call?
Absolutely. Commissioner?
Yes.
Michael?
Yes.
Bayruth?
Yes.
Mark?
Yes.
Cassandra?
Yes.
Matt?
Yes.
Lou?
Yes.
And Nancy?
Yes.
And Rena?
Yes.
And I would just add, first of all, thank you. But second of all, we clearly hear the request to come back to the board with further analysis and any adjustments on the personnel line. Thank you.
Thank you.
Terrific. Thanks, Lou, and thanks, everybody. I think now we're moving to the last item on the agenda, which is the membership survey research findings. I'm not sure who I'm turning that over to, but it's not going to be me.
That'll go to Marissa, I think.
Marissa, you're up.
Yes.
And Nikita, who's a first-time presenter. So welcome to this forum, Nikita.
Great. Thank you.
Okay.
Take it away.
Peter, we're not as mean over Zoom, so you're lucky.
Good morning, everyone. So today we have results from a few surveys of non-group members to share with you. I'll walk through our customer experience survey, which we've fielded annually for the last 5 years. It's a very lengthy survey that covers all aspects of membership. And we work with a vendor to design and conduct the survey, and they make sure we're reaching a representative sample of all kinds of members. And then I'll turn it over to Nikita Thopper from our team, who, as Louis mentioned, is presenting to the board for the first time today. And she will share findings from 2 smaller surveys we field in-house each month, one to new members and one to terminating members. And these are short targeted surveys. And while we invite all subscribers with an email address to participate, we don't do the same kind of sample stratification as we do on the customer experience survey to ensure balanced representation. So this spring, we ran our annual non-group member survey, which we used to run in August, but we've shifted the timing so that open enrollment and the associated decision-making process would be fresher in respondents' minds. About 2,400 current and former members representing all types of non-group enrollees participated. And throughout the presentation, you'll see asterisks to denote statistically significant findings, meaning that the difference between groups of members or over time is not likely to be based on the particular sample of members who responded to the survey this year. In terms of key takeaways, overall satisfaction increased significantly over the last 2 years to 80%, but affordability remains a key driver of dissatisfaction and a barrier to care. And we see members outside Connector Care much less satisfied. Members also continue to cite website navigation and noticing as areas for improvement. And finally, the Health Connector continues to help members transition between different types of coverage. And we saw a reduction in the number of members reporting being uninsured after leaving Health Connector coverage, which is great. So moving into member satisfaction, overall, 80% of respondents were satisfied with their Health Connector experience, up significantly from the 69% satisfaction we saw in 2018 and 2019. And in particular, former members expressed much higher levels of satisfaction this year. A few changes may be driving this change in part. First, we switched the timing of the survey from fall to spring. So it's possible that members had a positive interaction with us more recently coming out of open enrollment that's fresh on their minds, or maybe that former members in the sample chose to leave at the change of plan year rather than maybe having lost coverage in the middle of the year for an administrative reason or non-payment. And fielding also happened to coincide with an escalation of the COVID pandemic in late March and early April, which may have made people more appreciative of their health insurance. So we did press on that a bit with our vendor by looking at whether satisfaction reports increased over the course of the fielding as the pandemic worsened, but we did not find any differences in earlier versus later surveys. Respondents cited customer service, affordability of coverage, and the website as both the highlights of their experience and areas for improvement. And as we'll see in the subsequent slides, this seeming contradiction may be attributable to the wide variety of premiums our members pay, as well as the complexity of their household circumstances and maybe kind of their historical context for their health insurance experience. And we've just included some direct quotes from respondents here as well, which are always helpful to see. Diving more deeply into the data, we see that there's a divide between our Connector Care and our non-Connector Care members in terms of their satisfaction, with non-Connector Care members significantly less satisfied and less likely to stay enrolled with us in the future or recommend us to others. However, they aren't experiencing any more problems with their coverage than Connector Care members. So they may be less satisfied because they have that big monthly premium amount kind of front and center in their minds as they think about their experience, or perhaps because they're more likely to have come from employer-based coverage where they may have had richer benefits with lower costs and didn't have to manage any of the enrollment process themselves.
There's probably an affordability issue too, Marissa. I mean,
yes,
right.
Affordability for sure is a huge driver of a lot of the trends that we see going forward. It's not the first time or the last time we'll talk about it in this presentation.
Yeah.
So splitting the non-Connector Care population out by their plan's metallic tier, we see that bronze members in particular are unhappy. The lower satisfaction ratings on choice of doctors and hospitals are particularly interesting since networks generally vary across carriers rather than across metallic tiers. One explanation for this could be differences in the mix of enrollment by carrier within the tiers, or across the tiers, where bronze members are more cost sensitive and maybe choosing narrower networks, while gold and platinum members may be purchasing plans from carriers with broader networks. And it could also reflect this general feeling of dissatisfaction among bronze members related to those plan costs, that kind of just pervades and colors their whole experience on other factors as well.
Marissa, do we have, we've done member surveys in the past. Do we have any data with which we could look at trends over time? I think in particular, many of the products have moved towards more select networks. And as that has happened, I mean, it'd be interesting to see it. Has that appreciably affected satisfaction with choice of providers or not?
Yes, yep, we can definitely look at that. And, you know, that's something that we have been looking at in some of our historical data. As we've seen each open enrollment, more and more people move to those bronze plans. We've been particularly interested to track some of that information. And we can definitely provide that to you. But that is something that we've been looking at, and there has been a degradation in satisfaction, particularly I think as more people who are not the typical bronze plan enrollee that you might think of are moving to bronze to try to save money.
Yeah.
Okay, so here's a deeper dive on affordability, which, you know, as we mentioned, is a key factor in satisfaction. As premiums have risen over time, members increasingly report feeling that their premiums are unaffordable. And this is true in Connector Care as well, that there has been a decrease in the number of members saying that their premiums are affordable. We added a new question this year about the affordability of cost sharing as well. And you can see in those results the trade-offs that enrollees in different metallic tiers are making, where, you know, bronze members are maybe okay with their premiums, but their cost sharing is more onerous, and the inverse for gold and platinum. And there are significant differences among all program types, all metallic tiers here from the overall in these questions.
When did we stop doing so much premium smoothing?
Oh, was that 3
or 4 years ago?
3 or 4 years ago, yeah.
Maybe 2016 or 2017 was the plan year.
Yeah, yeah, I mean, it'd be interesting. I mean, on the one hand, when you look at the data in an aggregated way, a higher proportion of our members are Connector Care, so that should actually moderate some of the trends, but it's probably muted a little bit by the premium smoothing.
I have a question. This is Matt from the GIC, and this is, I should probably know the answer to this, but to Nancy's question on the last slide.
This slide?
Yeah. When carriers, or together we, calculate the actuarial value to slot them into the appropriate metallic tiers here, the network design is not a direct factor. Am I correct in saying that? That the factors in determining actuarial value really relate to the plan design features and the cost sharing features. Is that correct?
Yes, that's correct.
Thank you.
So no other questions on that component. I'll move over to a section on choosing and using coverage, where we ask people about their process for selecting a health plan. And we found in prior years that premium cost is the primary driver of plan choice, followed by the availability of a preferred provider, although people tend to rank all dimensions of a plan as being important to them. Among this year's respondents, about half indicated that they didn't shop or weren't sure if they shopped for a 2020 plan. And then in a follow-up question to those individuals about why they didn't shop, 3/4 of them said that they were happy with their plan. So that's good news. If people chose a plan that works for them the first time, they might not need to revisit that decision every year if their plan stays pretty stable. But what we're more concerned about is the 15% of non-shoppers who said that they didn't shop because they weren't sure how, and ways that we can find to support those members if they feel like they need to change and they need help to do that. A majority of members reviewed 2 to 4 plans, with unsubsidized members significantly more likely to have reviewed 5 to 7 plans when making their choice. And then over time, in this chart on the right, fewer members have said that we have the right number of plans, with about 17% thinking that we have too few plans. And we also asked this year about whether members would prefer we offer a smaller, more tailored shelf or offer more plans that they can filter themselves. And 2/3 said they prefer a broader shelf with filtering tools, though that preference was significantly stronger among unsubsidized enrollees. 70% of members said that they were happy with the plan they chose for 2020. And we added a new question this year of those who didn't find a plan they were happy with, to see what kinds of plans might be missing from our shelf. And I think this feeds into that question about, do we have the right number of plans? I think sometimes those responses are less about the actual number and more about the plan that somebody was looking for. And, you know, we had a supposition that people might have felt dissatisfied with our offerings because what they were really looking for is kind of this, you know, platonic ideal of a health plan that has low premiums, low out-of-pocket costs, and their preferred doctor, as well as a broad network of prestigious providers just in case they get sick. And while we may not be able to offer this kind of perfect plan, we were interested to see if there were other types of plans within our control that we should be considering, like PPOs, or if factors out of our control like cost were really the key drivers of dissatisfaction here.
It's probably worth highlighting one of the takeaways that I get from this slide. Sorry, this is Matt from the GIC. Looking at that table on the right of the things that they did not find that they were looking for, really the top 2 relate to affordability for them. And those far outpace the 3rd item, which relates to the preferred doctor or hospital that is in their plan. So I think as we evaluate and think about network-based plans, whether they be tiered or limited or select, whatever we want to call them, it's worth noting that those, you know, when you're looking to make a trade-off as a consumer, I see here the desire for lower cost at the trading off, you know, access to their preferred doctor or hospital. Unless that's one of the takeaways I have. If I'm misreading that or someone has a different take, I'll be interested.
I think it could also be, Matt, that they, for the most part, they could find a plan with their preferred doctor or hospital because there's so many choices, perhaps. But there's general dissatisfaction, as we know there is with price. It'd be interesting, Marissa, to see these split out between connector care and non-connector care. Was there much difference in the sort of percent in the ratings for these?
I don't believe there was. I've tried to note throughout where there was a big difference, or even if not significant, substantial difference between different program types. But we will follow up on that and we can provide you the program type breakdown for this.
This is Lou Malzone. I just wanted to interject here that, you know, forever I've been saying that we keep doing these surveys, but like most consumer issues, there's a balance between choice, too much choice, too little choice, in costs. And somewhere along the line, you know, when you ask the question, if people want more choice, obviously they always do. I mean, I've never heard anybody say, no, I don't want any more choice. But when you ask them if what's their major concern, and if it's affordability, and you said to them, if you had less choice, we could provide a much more affordable product, and the concern over choice disappears.
Yeah, so
I think that needs to be addressed at one of these surveys. I don't think we've ever addressed it. We keep getting these surveys back, and I've been on the board since 2006, and continuously am concerned about the fact that we keep adding choice, which has an implication directly of potential more cost, but indirectly more cost because it's got to be administered, and we continue to try to solve everybody's problem and be the answer to everybody's concern about being able to pick a plan, which they don't pick anyhow because it's too confusing, as the secretary said earlier. This much choice is, for somebody who's been in this business for a long time, there's way too much choice in plan design. So take that for what it's worth, but.
Yeah.
Thank you. I would say, first of all, that I hear you, Lou, and with regard to our survey planning for next surveys, I think we should juxtapose the choice versus price issue in some way. I think our connector care program itself is a program that effectively narrows choice in order to maintain lower pricing. And so I think there's a lot to be said for that. I find it very interesting that it's the unsub members that would like the most choice. And I don't know if that's just in the hopes that they can find a more affordable premium with their docs somewhere out there or not. But I think it's the unsub APTC that are particularly faced with these choice issues right now.
So I think we have about 25 more minutes, which is fine. We can continue this discussion, but I think the point that Lou was raising, which is important, is because there are trade-offs, you can't always say if people are unsatisfied that we have to make certain changes, because if you make changes in one dimension, increasing choice, you'll make changes in another dimension, increasing price. We can have this, I view this sort of as a snapshot of where we are. I think the question broadly is having a discussion at some point about how to interpret how we react to these things. Obviously, lower prices, lower out of pocket, and more choice is better. It just turns out that that's not exactly something we're able to deliver throughout. I do think compared to the federal exchange, we do a much better job at standardizing benefit design. So I'll let Matt go ahead.
Yeah, thank you. So one of the things that, of course, this issue of the trade-off between choice and kind of leverage and therefore cost is something that the GIC wrestles with as well, and will continue to wrestle with. One of the things that we are proceeding with over the coming months is a particular kind of survey that from what I understand about it, is actually designed to force the kinds of trade-offs that we are discussing here. It's a conjoint survey, which we're doing with Deloitte with our members, and we're essentially asking the question in the way that we're talking about here. I haven't seen I don't think the specific questions have been drafted. I wish I could give you an example, but it is really designed to set up a survey that forces choices. And we're happy to kind of stay in touch with the connector staff about our experience with that survey and whether it gives us the kind of insights that we hope to get.
That would be appreciated, Matt.
Marissa, do you want to keep moving along?
Sure thing. So one trend we've been watching is people who indicate having cost as a barrier to care. About 20% of members indicated problems paying medical bills, including among connector care members. And about 17% of those who had trouble paying bills said that a medical test or surgical procedure caused those bills, followed by prescription drugs. And I'd also note 13% of those having trouble struggled with dental care, which is a theme that we'll see over the next few slides as well, related to barriers to care. We added a few new questions this year about medical debt, which is a topic area that CHIA also explores in their biennial household survey. 20% of our respondents indicated having medical bills that they're paying over time, which is slightly higher than the 16% of respondents to CHIA's 2019 household survey who indicated medical debt. However, the majority of our members with debt owed an amount under $2,000, while respondents to CHIA's survey tended to owe higher amounts. About a third of those with bills being paid over time indicated that they were for care not covered by their plan. And about 24% reported deductibles and other out-of-pocket costs, each driving those bills.
And Marissa, did this vary much between connector care and non?
I do not believe that there was much variance there, no. In addition to struggling to pay for care received, nearly 23% of respondents indicated delaying or foregoing care to avoid cost, with unsubsidized and bronze enrollees significantly more likely to report delaying or skipping care based on cost. 35% of those who deferred care delayed a diagnostic test, 30% routine care, and 24% prescription drugs. We separated out dental and vision care this year into its own question to better assess costs that were associated with care that would actually be covered by a qualified health plan. And 48% of respondents in that question reported delaying or foregoing dental or vision care in the last 6 months. The survey also asked members about their relationships with and use of providers. So over half of members have a doctor's office where they usually go if they need care. And 2/3 of members said they received preventive care through their plan, while smaller proportions received care for an illness or injury, visited a specialist, or received mental health care. About 17% indicated they hadn't used services in the last 6 months. Members also reported having fewer problems gaining timely access to an in-network provider than in prior years, which is hopefully the start of a trend, but it is definitely something we'll be watching in future fieldings. Both given the difference that you see here, a bit of a drastic decline from prior years, as well as some of the ongoing concerns with increasingly narrow networks that we just discussed related to the seal of approval process.
Marissa or Nikki, in future surveys, we should, especially with the way things have been going with the coronavirus, is that how telemedicine has impacted some of our people, or not impacted it because it's been not available to our cohorts. But I know in the marketplace, the telemedicine situation needs to be addressed, and it looks like it's growing in popularity because you can't go to a doctor's office, so you much more prevalent today than it was even 6 months ago.
Lou, I can add to that. Blue Cross Blue Shield of Massachusetts in February saw 5,000 telehealth visits, and in March they saw 250,000, a 50-fold increase in telehealth visits. That's just one carrier.
And we've seen that at the GIC as well, similar trends.
Although,
So Marissa, do you think that the fact that this was fielded in March and April influenced any of the results?
We do ask about coverage over the last 6 months. So, presumably people should have been reflecting on a period of time during which coronavirus didn't play into their decision to seek out care. I might be a little bit more concerned that there's a change here related to the fielding period. So if you just signed up with us in January, you haven't had much time by the end of March to kind of use your care as if we had fielded in August or September, where you'd been with us for 8 or 9 months already. So that was an area that I was thinking might have played in a little bit more than COVID. But I think that's in particular why we have this question kind of on our watch list for next year to look at trends and changes.
okay, thank you.
All right. So 14% of members indicated that they delayed or did not get care because they couldn't find a provider who took their plan. And we added a question this year to see whether members tried to work with their carrier to find a provider if they were having trouble. 32% indicated they did. Bronze members were significantly less likely to have reached out to their carrier carrier at only 8%, while Black enrollees were significantly more likely to have called their health plan to help resolve the issue at 72%. Okay, and now, if no other questions about this survey, I'll turn it over to Nikki to tell you about our other surveys.
Good morning, members of the board.
Can I ask? Can I
Yep.
just ask one? Can you go back to the last slide?
Mm-hmm.
What do you make of the doubling in 2 years of people saying they don't have access to diagnostic tests?
You know, that to me is an area where, you know, for people outside connector care, your deductible comes into play pretty quickly. And so some of those may be things that people think that they can forego if it's, you know, kind of a cholesterol test associated with their annual physical or something like that. But I think we are interested in following that trend a little bit more, because that is one that has been growing along with prescription drugs.
Yeah. And sorry to have interrupted you, Nikki.
That's no problem. So today, as Marissa said earlier, I'll be sharing findings from some surveys we fielded in-house to new and terminating members. These surveys were deployed to understand how the COVID emergency impacts decisions people are making about their health insurance now. Please feel free to stop me if you have any questions as I'm going through the results. At the highest level through the survey results, we found that COVID drove some previously uninsured people into coverage out of fear of a health or financial risk, but didn't appear to push people out of Health Connector coverage for affordability reasons. Results from both of the surveys that we fielded also clearly illustrated that the Health Connector is most often used as a way station to prevent any gaps in coverage through life transitions that people may be experiencing. So I'll start with the new member survey. In the new member survey, we ask members questions about how much time has passed since they were last enrolled in a health plan, where they previously got their health insurance, and how they heard about the Health Connector. For this fielding, we also included a new response option related to COVID to discern new members' motivation for enrolling in coverage now. As you all know, one of the key protections that the Health Connector offered to help Massachusetts residents get covered and then stay covered during the duration of the emergency was opening a new special enrollment period to provide uninsured Massachusetts residents an opportunity to enroll in a subsidized health plan if they were eligible. So the results from this survey in particular provided important insights about those who used the COVID special enrollment period to enroll, and the results that I'll present in the subsequent slides sort of compare COVID SEP enrollees to overall new enrollees, so you'll get to see that distinction. So just in terms of survey logistics, we had approximately 22,000 new members enroll in a Health Connector plan beginning either in April or in May, primarily through either the new COVID special enrollment period or our existing loss of minimum essential coverage and connector care special enrollment periods. So the survey went to new subscribers who had an email address, of which approximately 1,400 completed the survey for a response rate of approximately 9.6%, which is slightly higher than the response rates in previous months. So the first question we asked new members is about any gaps in coverage they may have had before enrolling in their current health plan. So we found that among overall new members, approximately 43% had a gap of less than a month, while COVID SEP enrollees were more likely to have longer periods of uninsurance, with approximately 37% reporting gaps over 3 months.
Nikita. Hi, sorry. I had a question as you were going through this in particular. Do we have crosstabs on the survey in terms of demographics of ethnicity, race, age? I think that would be particularly, I think, helpful and through this lens, especially as we're thinking about COVID impact and insurance.
Sure. I didn't detail those crosstabs in this presentation, but we can certainly circulate information regarding demographics. Not only are we able to do that with the survey results, but we've also been looking at a COVID special enrollment period enrollees as a whole. So we can certainly share a more holistic picture of who is enrolling through this special enrollment period.
Thank you.
For this slide, I'll also add that just over 2% of the COVID special enrollment period enrollees reported that this was their first time ever having coverage, which mirrors the trend that we're seeing among all new members. And so next, we asked new members about their prior source of coverage before enrolling in a Health Connector plan. And here we saw that approximately a third of COVID STEP enrollees reported that the Health Connector was their prior source of coverage, while other new members most often reported having coverage through their job. Those who reported having coverage through their job were likely to have enrolled through a special enrollment period based on their loss of minimum essential coverage. So I also didn't break out the results, the new member survey results by April and May enrollees, but I did want to note that we saw a substantial increase in the proportion of members who indicated coming to us from ESI between April and May, which likely reflects the increasing volume of job loss that occurred during that same time period. And I think you'll see that borne out in the responses presented on the next slide. We also ask new members their reason for no longer having their prior coverage source. So among all new members who indicated that their prior coverage was ESI, nearly 2/3 of all new enrollees and half of COVID STEP enrollees reported not being covered through their employer because they were no longer employed. And then you'll see that there were about 17% of COVID special enrollment period enrollees who indicated some other reason for not having ESI. And upon reading the verbatims, saw that many reported that they were laid off due to the COVID emergency. Among members with prior coverage other than ESI, nearly 2/3 reported having some sort of change in circumstance that caused them to no longer qualify for their prior health plan. Approximately 30% of COVID STEP enrollees listed some other reason for not having their prior coverage anymore. And in reading those verbatims, we saw that many people cited losing coverage through their spouse or retiring.
I think these data just show how important it was, and kudos to the staff for recognizing this very early to let people enroll in health insurance as a result of the pandemic. So the states that didn't do this, I think there was a lot of suffering that could have been avoided. So.
Yeah, that's a great point. So finally, we asked new members about their motivation for getting health insurance now. Here, approximately 33% of all new members and COVID STEP new members indicated that it was important for them to keep themselves and their families healthy. COVID STEP enrollees were more likely to report needing health insurance to help pay for healthcare, and they were more likely to indicate that they were afraid of not having health insurance during the COVID emergency. I'll just make one more note that in these new member surveys, we like to ask how members heard about the Health Connector. And in this particular fielding of the survey, many new members cited getting information about us through the Massachusetts Department of Unemployment Assistance. So before I move on to our terminated member survey, does anyone have any questions?
Nikita, just do watch the time, please.
Sure. So I just have one more slide, and this is on a member survey that we sent to former Health Connector members who terminated their coverage for May to better understand why they canceled their health insurance and to see if they might be headed for uninsurance due to the impact of the COVID emergency. So this particular survey was fielded to approximately 1,900 termed subscribers, of which 107 completed the survey. That's like a response rate of 5.6%. Here we decided to exclude members who were known to be going from the Health Connector to Mass Health, because we obviously knew that they would be covered. So when asked their main reason for ending their health coverage, roughly 3/4 of former members indicated that they had a health plan through a new source. Of the 18% who indicated some other reason for ending their plan, most people specified that they recently turned 65 and were transitioning to Medicare. We were glad to see that no terminated members identified affordability issues related to COVID as a reason for ending their health connector coverage. So that we were pleased to see that. And then finally, when we asked what types of health insurance they are covered by now, 44% of former members said they now had health insurance through a job, and 38% said they were covered through Medicare. And again, we were happy to see only one respondent indicated being uninsured now. I'll just wrap up my presentation if no one has any additional questions by saying that our monthly surveys are designed to be a short turnaround instrument for us to quickly collect information from our members to better understand who they are and how social and economic effects motivate them. So we'll be sure to continue sharing monthly survey trends along with COVID special enrollment period enrollees and what they look like. Happy to take any questions in our last few minutes, but if not, I'll pass it back to Marissa.
Marissa, we should probably go pretty directly back to Michael.
Sure. We have one slide. I only have to say motion to adjourn. So let's just go through the next slide, Marissa, and then I'll say motion to adjourn. But everybody else, be prepared.
Sure. So really quickly, this is a great source of information. We're going to use it to support our member improvements through our strategic plan. And we liked it so much, we're going to do one for small groups. So we'll be back to you in the fall with those results.
So I will just say as a way of commentary, this material is very, very interesting. And at some point, a longer discussion about how to interpret and react to it, I think could be warranted. But for now, I'm just appreciative that you shared this with us. So I'll say thank you. If there aren't any questions, I'm going to wait for 5 seconds. I'm going to ask for a motion to adjourn.
So moved, Mr. Chairman.
There we go. A second?
Second.
Great. Kath, can we do a roll call?
Absolutely. Commissioner?
Yes.
Michael?
Yes.
Ruth?
Yes.
Mark?
Yes.
Cassandra?
Yes.
Matt?
Yes.
Lou?
Yes.
Nancy?
Nancy had to step away to a faculty meeting.
Okay. Okay, and Rena?
Yes.
Great. So the motion carries. We are adjourned. Everybody stay safe and thank you, and particularly to the staff who is doing a terrific job and dealing with a whole number of issues. We look forward to hearing how it all gets resolved, but we are very appreciative. So thank you all, and we will be in touch.
Thank you.
Thank you all.
Bye.
Thank you. Bye.